Is the molecular test which is currently available, and I am happy to announce that on 3rd of February, Union Health Minister is going to launch a new scheme because Government of India has procured 500 gene expert machines and 121 are already there. India has 88 districts, so I think it should suffice at district level. So let us now see how we have traveled through the TB diagnostics. We started with the discovery of Mycobacterium tuberculosis, and the latest molecular test we have, which is quite successful, is Gene Expert, or it's a molecular test. And the advantage of this test is that it gives you diagnosis of tuberculosis. At the same time, it tells you that the bug is rifamycin or rifampin resistant or sensitive. So these are the two important informations which can be obtained within 90 minutes of performing this test. If you look at the threshold limits, I would like to emphasize that the threshold limit for this molecular test is very low. And I am happy also to announce that people are working, the same company is working actually on, and within a span of 2 or 3 years, they will come up with still lower level of detection limit, that is 10 colony-forming units per ml. I think that will be the revolution in TB diagnostics. You have this, actually I have put various kind of modules which are available, and the beauty of this is that it can be done at point of care also, which I mentioned, that the instrument which will be available in next 2-3 years can be done, but we call actually in tuberculosis as point of care, POC level. That means actually you are sitting in the field, patient comes, you can make a diagnosis. India is a diverse country where we have temperature fluctuations, environmental temperature fluctuations. So they have taken care of this also. It can operate with the solar system also. The solar energy can also be taken into account to give the battery backup is there. Now, if you make early diagnosis, what are the useful things actually as far as the community is concerned? As I said, that it can provide you information of whether it is actually MDR-TB or not. MDR-TB I am saying because rifampicin is used as a surrogate marker for the diagnosis of drug resistance, that is MDR-TB. And at the same time, actually, if you know that patient is infectious, then you can reduce the community transmission also. And the most important thing is that hitherto we have been struggling with extrapulmonary TB. So it is actually, I will share the data with you that it's useful in that setting also. Now, we just published last year, it is evident that in pulmonary specimens, if actually smear and culture is positive, it tops the list. That means actually sensitivity is very high, 99%. And number two, if you have all culture, including smear negative, culture positive, then you have about 96% sensitivity. Look at specificity. It is near 100%. I think it is an ideal test. However, as I said, the detection limit is still high. So they are going to modify it to make it ultra sensitive. This is a Cochrane review, systematic review, which was compared with our study, which was done actually in 1,000, nearly 500 samples. If you compare head to head, that sensitivity matches. And in smear negative and culture positive also, it's very close. And look at the specificity. It's 99%. I feel actually it is an ideal test. And what happens actually when you get reports, we do actually cultures also. We may do solid culture, we may do liquid culture these days, and we may have information from this molecular test also. So what we say that genotypic and phenotypic discrepancy in the result. So actually the third umpire here is doing genetic sequencing, and DNA sequencing can be done. 13 samples actually we could do with 12 samples, and 9 were more concordant with this test as compared to solid culture. So that means more concordance with genetic sequencing. Now I am going to, so far I have discussed pulmonary tuberculosis. Now I will be discussing about extrapulmonary TB, and everyone knows that this is a possibly diagnostic challenge, and this instrument or this test actually has got a potential role in the diagnosis. I want to introduce here a term. Hitherto we are familiar with gold standard, which is taken in tuberculosis diagnosis. It is taken as culture, mycobacterial culture. I am introducing a new term which is known as, in this actually with this molecular test, we are using, especially with reference to extrapulmonary TB, composite reference standard, CRS. It is a very commonly used term. What are we using in this? The components are clinical diagnosis, radiological findings, and other available diagnostic tests, like in pleural effusion we do ADA estimation also. And response to treatment. It is very important in extrapulmonary TB cases. So any one of these can be taken along with the culture. Of course, culture is also taken. It is a more than culture. So many variables, especially response to treatment, is very important in EPTB cases. I would like to share our results. If you look at the highest yield is with cold abscesses. Number 2, highest yield with the lymph nodes. However, there is a very poor, it is not a panacea for all the samples, like pleural fluid, ascitic fluid, and pericardial fluid and urine. It has got low sensitivity. It is understandable actually. The NAT or nucleic acid amplification is interfered by some natural inhibitors which are present in these fluids. You people also must be struggling with when you send cold abscess or some other fluid or CSF. Its culture is actually has got suboptimal performance. Likewise, smear has got the most dismal performance. So here is the panacea. I will say actually with the current, with the future tests being available, it will become actually, I think, number one diagnostic test. WHO had commissioned one systematic review on the basis of that actually they had said that it should be used as a number one diagnostic test. I have tried to compare here head-to-head the WHO review as well as, if you look at composite reference standard, the sensitivity and specificities are quite high, very encouraging. But there is a word of caution here that in other fluids, the sensitivity is low. So I will not recommend this test in all extrapulmonary TB samples. However, as actually mentioned in the previous list, they should be taken as good samples to be sent for rapid diagnosis. This slide summarizes various pulmonary as well as extrapulmonary TB samples with sensitivity and specificity. It is a good rule-in test because of very high specificity. So based on my presentation, I will say that it should be used as first-line diagnostic tool in patients with pulmonary and extrapulmonary TB. It's going to replace, mind you, I am using the words very carefully, it's going to replace Wien microscopy in future. And the already competent authority has taken a decision for country that it may be used because actually I told you that we have more than 600 machines in the country. So it will also at the same time increase notification rates in India, which are dismally low. And it has changed the it is going to change the current diagnostic landscape of TB diagnosis. And importantly, it will provide you information on RIF resistance, whether it is whether bug is resistant or sensitive. If it is resistant, you can use as equivalent to MDR TB. Of course, you need to wait for culture also. And I have introduced to you a new term, that is composite reference standard. I am really thankful for various agencies which have helped me in carrying out some of these studies in tuberculosis culture, smear, and this molecular test. I am really thankful to my group, which is very active at my institute. My institute also happens to be the intermediate reference laboratory for NCR Delhi. That is, it serves as one of the reference standards.